possibly, let me see, is there still music? One of the areas that we really wanted to focus on, especially, is mental health. Being a mental health nurse myself, I have seen and I've worked in psychiatric or mental health nursing, that it has been very involved and it's been very impactful on our community. So with that, I'm going to share some information in terms of my presentation on mental health and pain going on in our community. All right, can everyone see my slides? All right, I believe so. So, and moving on, thank you for the thumbs up. My slides here today are talking about mental health care and chronic pain management amid COVID-19. And so with this project, I've worked extensively. One of the leaders was on none other than Dr. Bazargan, as well as Dr. Sharon Asari. And they were able to conduct this study, which I've been able to assist on the back end, with some of the information on mental health and pain and chronic pain. So with moving on, I just want to bring some perspective on mental illness going on globally. The World Health Organization reports that mental illness is the leading cause of disability and a risk factor for various chronic illnesses. Approximately 1 in 5 adults in the US manage a mental illness. However, when we look at what it is in terms of what is a mental illness versus serious mental illness, we're going to get to that difference, because what I want people to realize is that there is a difference between mental illness and what we define as a serious mental illness. So for a serious mental illness, approximately 1 in 25 adults in the US, and that's 11.2 million people, manage at least one serious mental illness. So we've heard a lot, but now we're going to dig in deeper to what this means in terms of mental illness. So again, what is a serious mental illness? According to the US government, they define a serious mental illness as anybody who's 18 or over, who currently or at the time during the past year has a diagnosable mental, behavioral, or emotional disorder, and that disorder has resulted in functional impairment, which means that it interferes with one of their major life activities or limits one of their major life activities. You know, for instance, working, being able to do some of the functions of life. However, the definition has changed, because when this definition first came out, this was in 1993, but now they've started to go into how long that illness is. And so I just want to note, because a lot of times there's a lot of stigma around mental illness and what does it mean to have a mental illness. But I just want to hammer in the point that many of the individuals that we know may be suffering with a mental illness, even a serious mental illness, and just don't want to disclose it because of the stigma, especially in our community. You know, people don't want to be labeled as, oh, you're crazy, or, oh, here comes that mad person coming. And, you know, it's because of the stigma, but there are so many people that I've known throughout my career that you would be surprised on who's actually managing or battling a mental illness. So we just want to bring to light on what's the severity and what's going on in our community and what steps we could do to possibly fix this. So when moving on, some of the common serious mental illnesses include bipolar disorder, schizoaffective disorder, which usually includes schizophrenia, major depression. You know, just because I didn't talk about some of the other types of depression disorders, but there's minor depression. Some individuals might have what's known as the seasonal affective disorder, that they might have during different seasons, such as the winter, where they get more sad. We also have post-traumatic stress disorder. One time I remember that I met this lady, and she lost 3 of her kids to gun violence. One of her youngest kids was 2-year-olds when 2-year-old, sorry, they were 2 years old when they got shot by a bullet that it was not meant for them. And so she lost her daughter when that daughter was 2 years old, and she additionally lost 2 other sons. And so by the time I met her, she just said, she had trauma. She didn't want to hear about anybody else going through or being hit by or shot by a gun because of how much trauma she's went through with 3 kids. And so some of those things bring back trauma for them. And additionally, we think about it for other things that may occur in our life. When somebody gets cancer, for instance, when you're diagnosed with cancer and then you hear about, is it reoccurring, or when am I going to be healed? When am I going to be recovered? That can cause trauma in your life. And so a lot of times I link it to say, some of the things that we think, such as war or other major things such as a hurricane, that isn't inclusive on just what trauma means. Trauma can mean that somebody we know got paralyzed and that causes trauma for them, or they got cancer, like I said, and that causes trauma for them. And it's the stress of reliving that in their life that causes that type of trauma. So that's post-traumatic stress disorder. Also, we have panic disorder and paranoid disorder. And sometimes with this, we might have other common co-occurring disorders, which include substance use. So individuals might be using substances, illicit substances, in excess. Sometimes they might develop alcoholism. They might start on some illicit drugs, such as meth or cocaine. They might have common co-occurring disorders, developmental disability, and also potentially life-threatening chronic medical conditions such as HIV/AIDS. One thing I've also seen is that individuals who have a mental illness, sometimes they may be more likely to suffer from homelessness as well. So I just want to point out that individuals who are living with who are living with a serious mental illness may be at higher risk for multimorbidity, which means managing multiple chronic illnesses. So what have we done throughout the United States history to try to tackle this problem? Prior to 1963 with President Kennedy, there were a lot of things called asylums and different type of major institutions which house individuals who had mental health illnesses. There are also other medical ethical abuses that happened during this time. For instance, and I can share the book in the chat, but there was one time when throughout the 1960s where Black men were being labeled with schizophrenia so they could put them in these type of institutions. Unfairly, they were being labeled with schizophrenia and they were giving them more damaging medications than what to actually treat them with. And so this became very stigmatized in our community to be able to actually treat you for what you are, because we noticed that Black people, especially Black men, were being labeled incorrectly. So the President Kennedy's 1963 Community Health Act restructured to take down asylums and actually make them into community health centers to provide more services. He wanted to bring more effective psychotropic medications. At that time, we had stronger medications with more damaging effects, such as lithium. So we started to see new approaches to psychotherapy. And also we had trends toward less frequent and shorter medical and psychiatric hospitalizations, and more healthcare providers focus on community managed care. However, his plan stopped short. It was a great plan to try to transform mental health, but due to funding and due to a loss of all of these institutions, such as these asylums, instead, they were just pushing people out because they no longer could get funding anymore. So this resulted in all those individuals coming now and didn't have anywhere to live. So now they were homeless. And this is where a lot of that started to build up in terms of transient housing. Since then, from 2009, the federal government had cut $4.35 billion in public mental health spending. And this has been one of the largest reductions in mental health funding. Additionally, President Carter's 1980 Mental Health System Act started to try to provide grants to community mental health centers, but it was repealed in 1981 by President Reagan. So this far, and especially with Obamacare, it has now ensured that mental health was included in the 10 essential benefits for individuals in small group plans. So there now has been change in order to try to get individuals to be able to get some type of funding, or to be able to get insurance benefit, to be able to see a therapist, or to get mental health psychotropic medications. So why is this so important? Individuals who have a mental illness, they show them to die on average 25 years earlier than those who do not have a mental illness. And this is so important because if you're 75, that means if I have a serious mental illness, I'm expected to die at 50, almost 25 years earlier than you. And this is because they have a higher physical and mental health burden, and it's difficult for them to seek care. So this is why it's so important that we start to tackle mental health. It's also been very costly in terms of ER care. We're spending 38.5 billion. Incarceration, we've seen it 37 billion, and we've lost productivity. The National Alliance on Mental Health reports that untreated mental illness costs the country up to $300 billion every year. So what's some of the expected lifetime health and economic outcomes? And this just goes to show you what I just stated. If we look at the number of years after age 25, so if we're looking on 50, again, like I said, 75, those who have no serious mental illness before age 25, they can live another 56 years. But if I have a serious mental illness before age 25, I'm only supposed to live with it only 45 years. So we're seeing big reduction, and this is in general, but it doesn't even narrow down on how it's affecting minority populations, especially African Americans. So when we look at now mental illness, we have to also look at it in terms of chronic pain. This has been going on hand in hand, and this is because chronic pain is linked to mental illness, such as anxiety and depression. Arthritis has been found to increase mood and anxiety disorders. If you are having serious knee pain, you don't want to be bothered about some things, or you may not want to go out to some events because you have trouble walking. This can cause anxiety going out. Back and neck pain and migraines, this can also increase your risk for mental health, such as, again, if I have severe back pain, I might not want to go out to see my friends. My back hurts so much, I just want to lie in bed in one position. So this can also have some effects. Additionally, it worsens with untreated mental illness, and it can also decrease the success of pain management methods. And there's also something I want to bring into light, which is your physical pain versus the mental pain. You know, sometimes we may have where physically it hurts, but it can also be a mental aspect in terms of mental pain, knowing that I know it's going to come. Once I do this, it's going to hurt. And so we start to see the mental psychological pain. And again, specific groups are at higher risk for mental health and pain burden, especially those with higher exposure to trauma. So I think I put where, sorry about that, where has pain management been neglected during COVID-19? And this might actually be true. So we had some findings, but I want to go into the study that was led by Dr. Bazargan that we worked on. And this specifically looked at psychotropic and opioid-based medication use among economically disadvantaged older African-American adults. And within this study that was conducted, This included 740 older African Americans who in South LA who were age 55 and older. 64% of this group was female, and the average number of chronic medical conditions that they had were 2.4 conditions. And most importantly, 60% of these individuals, of these 740 individuals, reported living alone, which is high. And that means who's coming to check on you? Am I feeling socially depressed or isolated? Some of the pain characteristics: 66% reported arthritis, 48% reported back pain, and 19% reported that they have migraines. And if you look at this, the average number of prescription drugs that they were using among those who were taking medications for pain, opioid based, is 8.28 medications. Now, that's a lot of pill bottles when you're looking at 8 different ones, compared to non-opioid users at 5.41. And when we look at the average number of prescription drugs used among those with psychotropics, so mental health medication users, was 8.1. So that, again, that's 8 medications compared to non-users at 5.48. So what do we find in terms of relationships and linkages? Those who were taking opioids, those who were prescribed opioids, so that's the pain medication, those who were like tramadol, Ultram, those who were prescribed opioid medication had more depressive symptoms. They had higher levels of pain because, of course, opioids are primarily prescribed for pain, but they also had more chronic conditions. They had higher back pain, arthritis, but what's important is that they had more depressive symptoms. For those who were taking psychotropic medications, so that can be like Klonopin, Ativan, we've heard about some of those, even Valium. They reported higher levels of pain, which is very interesting, as well as migraines, back pain, and arthritis, and lower self-rated health. And that's important because a lot of times we ask individuals, how do you rate your health? And it's on a 5-point scale where we're saying excellent, very good, good. So when we're saying lower, that means that they might be more likely to say, well, my health may be fair or it's poor. And so this is something which causes concern, which we have to look into more. So when we look at this in terms of COVID-19 and its impact, clinical significant symptoms of depression and anxiety have more than tripled since the COVID-19 pandemic. So that means feeling sad, feeling blue. When I go out somewhere, I'm having panic. If I see somebody, if I have somebody who's living in my house and they are going to parties and not wearing their mask, I might be more anxious to be around them or even have them in my house and start to develop symptoms of anxiety. And also, I want you to remember that there's a social injustice pandemic going on at this time. We're seeing, I always bring into play racial injustice. We're seeing where the person who murdered George Floyd is now on trial. That can bring up so many things for people. We live in Los Angeles where sometimes police brutality have been called into question. And sometimes that can bring back memories for people. So we're also been fighting on the scenes here. Social distancing and quarantine. I think somebody remarked earlier how they're ready to get back into church. You're not going to do your favorite things or see the favorite people you love can cause loneliness and social isolation. There's anxiety and fear of contracting or managing COVID-19. We've seen that when it comes to testing and vaccination. This week, I talked to somebody and they were like, I'm scared of needles. I don't want to get a needle in my arm. These are serious things where people are fearful of not necessarily the COVID vaccine themselves, but maybe just the process. And we're also navigating a new healthcare system, which Dr. Rogers will talk on later. I also want to bring up some of the socioeconomic changes which might now cause some of the mental health changes we're seeing. There's a loss of financial income and employment changes. If you are a frontline worker, you're working at Costco, Home Depot, you might be working more, you might be working longer hours. it can be burdensome, especially if you also lost your job during this time. You had to get on unemployment. There are effects when it comes to mental health effects that come from this. Um, and there's also little benefits. Sometimes you just have to do what you have to do to survive, but you may not be talking about how this may impacting you, especially not only for you, but individuals in your family who might be affected with this. And for instance, if they got COVID, they had to stop working, they lost pay, that can impact their mental health. So we're seeing strain and inequitable healthcare system that commonly neglects marginalized, underserved, and underrepresented groups, and that there's a lack of cost-effective treatment approaches. For instance, when it comes to mental health, are we doing non-pharmacological approaches? So are we doing strategies that doesn't involve medication or that does routine therapy? And increased visibility of healthcare injustice, we've seen that. Geographic inaccessibility. How many of us know a therapist that we can refer to somebody if they're going through a crisis? What about economic disenfranchisement? Lower rates of insurance coverage, especially when it comes to mental health illness or even regular conditions, being able to go to a pain management specialist who can help you treat your pain, and mistrust of the healthcare system due to years of abuse, neglect, and coercive treatment. So what's some of the things that we can now start tackling when it comes to practice? We need to start asking our providers about when we go to them, doctor, how can I get effective pain management for sometimes my back pain or my migraines? Pain management strategies that may have worked before may not be effective due to COVID-19 now. And taking psychotropic medication, say your doctor prescribes you something for anxiety and you're taking pain medication at the same time, that's a cause for concern due to its effects. Especially if the individual contracted COVID-19. So we might use a process called medication assisted treatment to help reduce how heavily they're taking these medications. In addition, I put nurses because, again, I'm a nurse, but this goes for providers. They may struggle with internal role conflicts. How do I maintain professionalism versus taking a personal interest on patients? Some providers may be a little bit more cold to you, but that's because if they get heavily involved, they may cross the line as well, which can affect their performance. So at all times, try to start building a more harmonious relationship with your provider. You should be able to email them, develop a close friendship with your provider, because at the same time, when you're going through something, let's say you have a rash that you don't know, you should be able to take a picture and send it to your doctor and say, hey doc, what does this look like? Or can you refer me to somebody? That's how close that relationship should be. So building it up and having discussions about COVID-19, as well as building support groups. I always tell my churches, start your health ministry, get it going where you might have a support group to start talking about how you manage through things, especially something as loneliness. During COVID-19, it might help to start a support group or just if you have a prayer warriors group, to maybe 1 week out of the month, you focus on loneliness, because a lot of people are battling that. In addition, providers should focus on education and outreach efforts, increasing knowledge and treatment plan effectiveness. Do not overlook medical and mental health conditions. For instance, within the African American community, cancer usually tends to be diagnosed late among African Americans. And, a lot of times we need to bring forth to the table when we might be feeling something strange going on with our body that we're just not used to. Encouraging people, if they say, oh, my arm is hurting for some reason and I don't know, I can't lift it, tell your provider. Don't just let it sit there and say, I'll handle it or it will get better. That's a time for concern to start telling your provider. Also, I encourage others to always carry your medications on a document or phone. You never know what emergency you might be in or where you have to go. And it's quicker when you have that list of medications to provide to them to say, here are all the medications I'm taking, and here's my allergies. Additionally, we want to reduce the implicit bias and medical mistrust. We want to, it's hard sometimes to trust our healthcare system, to trust our providers. So sometimes you need an upfront thing to say, I don't know what you may think of me, but I'm a human being. And at the end of the day, I just want to be treated as a human being and get the same type of respect and care like anyone else. So that becomes increasing cultural and structural competency, finding a provider that cares about you. If that provider doesn't seem sensitive to your needs, then it's time to find a provider that will. And improve coordination of care and newer approaches to manage care. If you're suffering with pain, you should not be. It's time to find a provider who's willing to listen to you and make sure how can we make sure that your pain is being managed. In regards to some of the things, I'm going to skip because of time, but one of the things I wanted to link up, and this is what individuals, especially some of the leaders, Dr. Bazarka and Dr. Waller, everyone has been really crucial making sure is this community partnered participatory research. As a researcher myself, not only as a healthcare professional, but as a researcher, when I go into communities or when I see other researchers going into communities, you can't just come into a community, do the research, and leave with the results. You are there to strike a partnership and to be there to help one another, to build one another. And so we're going with that. That's why CDU is so crucial in making sure we build those relationships in order to help our community. SPA 6, which is where many of us live, it includes South Los Angeles and other communities such as Compton, Crenshaw. It's comprised of over 1 million adults, yet it is one of the most underserved, under-resourced areas in the nation. And typically it's affected by health disparities. The diabetes death rate in South Los Angeles is almost 5 times higher than that in West LA, which includes Beverly Hills and Santa Monica. So this is why this type of training is so important, to bring it home to our people to build our health. So one of the great leaders who pioneered this, Dr. Loretta Jones, who is the founder of the CDU Academic and Community Faculty Program, brought in this community partner participatory research, which had 4 steps. Identify a health issue that is prevalent within the community. Don't go in with your own biases, but you all as a group should be discussing what are the health issues that matter to us. If somebody's coming in to tell you about temporal mandibular joint disease, you should be like, well, none of us are maybe suffering, but what's at the heart? What is the health issue that's truly affecting our community that we need? Develop a coalition of community, policy, and academic stakeholders who can bring the science, bring the support, and engage the community through various methods. With information, as well as initiate work groups. One of the things I hate to see is when you've built together a nice plan that works for a while and then it stops. We need to start making sure that we are sustainable, that we are bringing the things that's going to last, that will bring in younger generations to also continue that work. We have to make sure that once we do something, it just doesn't end after a period, that it's sustainable and keeps continuing. Also, some of the experience of managing both physical and mental pain. We need to bring in social determinants of health. Again, the post-traumatic stress of COVID-19 is going to be lingering for so long. One afternoon or evening we were on with some of the pastors, and Dr. Waller was present and probably could talk about it after this, is that, a lot of our pastors have had to do so many funerals, and it can be intense, not only for the family, but also for leaders. Imagine, especially for pastors, first ladies, church leaders who are going through and they have to do the funerals, write the resolutions. You know, for so many families, that can also lead to a lot of grief, a lot of strife within a lot of us. So it's also looking at the post-traumatic stress of COVID-19. So we want to empower individuals to be at the center of their care. As you take this, ask individuals to know that they are the center of that healthcare team. It's their health. If they don't take charge of their health, who will? You have to be your biggest advocate and be able to participate in a shared decision making. And so with that, I will end. And I believe, I'm not sure if there are any questions or concerns in that, but we wanted to share a little bit on mental health and pain, and if you have any questions for myself. All right. I think, thank you. I am not sure if Dr. Adinkra wants to take a break, but I just want to hit home on some of those messages. Encourage individuals that you come into contact with to take charge of their health. Don't just let it sit there in which, they don't even understand what that patient is going through. This week, I had to help somebody who is going through a surgery to remove a mass, and they didn't even understand what the doctor was saying. I said, sit down with them and sit down, stop them, and explain everything that's being done to you. That's the normal thing, because if you don't understand what you're going through, who else? Your family. And then you look up and you're like, well, how did I go through this? What did they actually do? You are the one in charge. You are the one going through it. So make sure to take action over your health, empower those who need to. If you need to bring in a nurse or any other provider, a doctor who you know outside to come and help and step in and say, can you read this progress note? Can you translate it for me? A lot of times we don't even read our own CT scans, our X-ray readings, and sometimes we may pick up stuff that the doctor just gives us a summary, but when you read through it, you're like, oh, wow, this is really here. So please make sure we're empowering individuals to take care of their health. So with that, Dr. Dinker, I don't know if we're going to break or we're moving on to Dr. Kathy. Thank you.
Take a 5-minute break and come back to Dr. Kathy.
Thank you.
Thank you, Dr. Cobb. Great job.
Hi, cousin. I had to